Hello everyone, welcome to this ESGE satellite webinar series with the help of SonoScape and the European Society of Gastrointestinal Endoscopy. You see, we start with some music of hope. My name is Helmut Neumann from Germany, and it's really a great pleasure that you today are all with us to talk about what shapes the future of endoscopy, what is the emerging evidence, and what are the new perspectives. And I'm very, very happy to introduce my colleagues today because it's a multi-center initiative. Today we have Professor Cesare Hassan here from Italy. Cesare, hello.
Hello, Helmut.
Hello, we have Professor Lucian Negranu from Romania in Bucharest. Welcome, Lucian, hello.
Hello, everyone.
Hello, and also we have Pedro Rosson, Professor Rosson from most beautiful Malaga and Spain. Welcome so much, Pedro.
Hello, Helmut, thank you.
Hello. And later on, we also hope that Professor Marc Giovannini will join us from Marseille in France. And this webinar today will be a very special one because we have experts from various countries in Europe, but also we have you. So what we're doing today is not only talking about emerging evidence, but we also ask you to participate actively. So we have a voting poll during this webinar so you can actively participate in this symposium. And our aim is to just give you all the details within just 1 hour. So I think we want to definitely start. But before we are starting, again, I want to deeply thank SonoScape company for this initiative, providing us here with the latest knowledge. And of course, also the European Society of Gastrointestinal Endoscopy, the ESGE, for supporting this event. So Cesare, maybe we can start with your talk about novel light spectrum and contribution to an increased detection rate.
I agree that this partnership between SonoScape and ESGE will be long lasting, and we are so excited about it. So as you know, what I do is mainly screening colonoscopy, and there is still an unsatisfactory variability in adenoma detection rate across the all endoscopists. You can find one adenoma in 20% of the patient and some other endoscopies in 80% of the patient, and this has been associated with interval colorectal cancer. If you do screening colonoscopy, you know that most of the difference across the endoscopy is related with a diminutive flat adenoma. You can spend 7-8 minutes of withdrawal, and the only adenoma that you find is this lesion. If you miss this lesion, you will not find another one in this patient. Next slide. So the problem is, why are we missing the smallest? And there are, of course, several reasons. First, it may be the inadequate cleansing. Secondly, maybe we are rushing too much. Third, our technique of rotation and tip movement is not enough. Of course, we only like a high definition scope, but the main problem is probably the inadequate level of contrast between the normal and the adenomatous mucosa. Next. So the main issue is whether we can use advanced imaging to increase the contrast between what is neoplastic and what is healthy. In the SonoScape platform, I like to use the VIST, that is a physical and optical filter in order to create a blue light. You will hear a lot from Helmut about the use of this light for characterization. The problem is, should we use a blue light for detection? Next slide. So this is an example. You may see, can you activate the video, Claire, please? You may see that on the left we have white light, on the right we have VIST. We have the increased vascularity of the lesion that create a contrast that simplify the detection. Should we use this blue light for our screening colonoscopy in average risk subject? Next slide. Go next, Claire. So the answer may be Yes, because the blue-based Chroma endoscopy can increase the contrast between the normal and the adenomatous mucosa, and it will simplify the adenoma detection. There is a big literature with the use of NBI by Olympus showing that if the level of cleansing is adequate, you can increase by 30% the detection of adenoma when you use a blue light like VIST on the SonoScape platform. However, next again, I want to be honest with you. I don't like to use a blue-based Chroma endoscopy for my screening colonoscopy because, for instance, it emphasizes too much the stool that appear as red as the lesion. In addition, it is too dark, and this increases by at least 1 to 2 minutes the withdrawal time, and you need to be very close in order not to miss the periphery of the image. Next slide. So the paradigm shift by SonoScape and other company is to use not a blue base, but a bright Chroma endoscopy for detection, a special light only to increase detection. Next slide. In the platform of SonoScape, this has been named as SFI. In this light, you still have the enhancement by the blue light, but there is a new red component that generates a bright background that is similar to white light. So you can work for hours without getting exhausted. Can you activate the video? What I like of SFI is that what is red become reddish, and what is white become whitish. This is extremely clear in this video, always of the same adenoma. On the left, you have the blue base VIST. On the right, you have SFI. You may see that SFI is much more similar to white light, but you still have the contrast of the blue base component. So the idea is to use this for screening colonoscopy. Next slide. Next, okay. So why not to use this? It preserves the same contrast between adenoma and normal mucosa as the dark Chroma endoscopy. There is no interference from the stool that are green and blood that remain red as preserve all the other color. And there is a bright background in the peripheral part, so you don't need to increase your withdrawal time. Next slide. We don't have direct data with SFI, but this is a study done with a very similar technology, is LSI by Fuji. And in this trial that we did in a Fit Positive program, you may see, can you click, Claire? That, no, go back, sorry. That there is a 20% increase in the adenoma detection rate when using this bright Chroma endoscopy to detect more adenoma. So this is what we recommend. Of course, next slide. The future is about combining advanced imaging with artificial intelligence. Can you activate this video? This is an historical video, the first done with GI Genius by Medtronic on SonoScape platform with SFI, and you may see how the box detects the lesion. So will SFI help GI Genius in detecting polyp or not? This is the next challenge. Of course, artificial intelligence is able to increase by 40% the ADR. So in conclusion, colonoscopy is effective, but too many lesions are missed. Blue-based Chroma endoscopy is theoretically appealing, but is unfeasible in everyday routine. But the bright Chroma endoscopy as SFI is the way that I recommend, is the way that I use in my routine. Thanks, Helmut, and back to you.
Thank you so much, Tira. It's always a great pleasure listening to your fantastic lectures and learning so much from you. And definitely we're seeing so often during those even challenging times, at least online. Look so much forward to seeing you in person again, hopefully soon again, and all of you, because we have already more than 280 participants at the moment. So thanks for all of you joining us in these challenging times. And again, thanks to SonoScape and thanks to the ESGE. Cesare, most recently you have released the final or the last guidelines on colorectal screening, cancer screening as well. Do you see any idea of using SFI in the future? Should we maybe use really dedicated detection tool to increase our detection rates?
Yes, I feel that we are not using in the future white light. We will be using SFI or whatever is new, but white light will not be in the next 10 years in the field of colonoscopy.
Thank you. So it shapes the future of endoscopy, as you can see. Thank you very much again, Cesare.
Thanks.
So thank you so much. So we go to the next talk. Before getting ready for AI, for artificial intelligence, I want to show you the new valid classification, a smart way for in vivo characterization of colon lesions. And for this one, we are looking forward to get the new presentation. So as you can see, we have a specific challenge in the diagnosis, and this includes lesions which are very flat, which are hidden, so located, for example, behind the colonic folds, or even located in chronically inflamed mucosa, like this is the case for patients suffering from inflammatory bowel disease. So indeed, there is a very strong need for advanced endoscopic imaging techniques for both detection and also, of course, for characterization of colorectal lesions. So SonoScape is now offering a new optical chroma endoscopy system, and Cesare already has highlighted this new optical chroma endoscopy system for us. Again, we have two specific types of chroma endoscopy. One is called spectral focused imaging, a tool dedicated for detection of lesion, and the second one is the so-called VIST or VIST, versatile intelligent staining technology, and this is a mode specifically dedicated to detection. So you can see we have high definition white light, the SFI mode for detection, and the VIST mode for characterization of lesions. So always for us, very important, of course, is the question, is it now effective to use image-enhanced endoscopy, and specifically even those tools for detection and characterization? We just want to highlight this short video so you can see that there is a lesion, and now we have switched to SFI. Already Cesare has highlighted the color change here. The red colors are increased, and then you can clearly demarcate the lesion. Afterwards, you're switching to the VIST mode, and after switching to VIST, you can clearly identify the surface pit pattern morphology of this colorectal polyp, and you can clearly identify indeed that this is a hyperplastic lesion. Like for every new technology, dear colleagues, we are always asking the same question. Is it now comparable to existing ones? So SonoScape for most of us is a new company, although we have to state that SonoScape is strongly supporting the ESGE now since 2018. Or maybe even 17, because they have been present at all the conferences. And unfortunately, this year we have been not able to meet in person at the ESGE days, but of course we still hope that we'll be able to meet next year and to see you all in person again. So is a new technique now comparable to the existing ones? And we have done an international multi-center controlled trial from China, Thailand, Italy, of course. Professor Hassan participated as well, Russia and Germany as well. And the aim was to investigate the key performance parameters of colonoscopy of SonoScape and other established brands. So we have had a look at the performance parameters, including the cecal intubation time, the total examination time, and the number of polyps detected. So most important, as you can see here on this table, and I only want to highlight the result, that there was no significant difference noted for the cecal intubation time, neither for the withdrawal time or the polyp detection rate between the individual brands. So SonoScape, the new brand, was not inferior to Olympus or even Pentax Medical, as you can see here in this study. And also, there was no significant differences in the adenoma detection rate in between the subgroup analyzers. So the question, of course, now is, what is next? And you can see this is a latest video processor here of it's a SonoScape HD 550 4 LED system. And what we have done now in the recent month is we have developed a new classification. And it was Cesare's idea to came up with this great name of VALID. It's the VIST appearance of colon lesions and histology prediction. And what we have done with this VALID classification is we just try to make a very easy classification for in vivo prediction of colorectal polyp histology. So what we have done, we looked at the surface pattern morphology. We're looking if it's regular, if it's irregular, or if it's ulcerated. The second one is we're evaluating the pit pattern morphology, and we are predicting if the pit pattern is round, so we can predict in hyperplastic polyp if the pit pattern appearance is a tubular one, a villus, or a tubular villus one. And then this classification, because the image quality is so crystal clear, we're able not only to predict that this is an adenoma, but we can predict the individual type of the adenoma as well. And then finally, if the surface pattern is ulcerated and the pit pattern is not visible, then we can predict that this is a cancer lesion, and this is the VALID classification. And I want to show you one example, and then I want to ask you to do a poll as well here. For the first time ever, we want you to participate as well. We have now 294 participants here, so we want to ask you to participate in this webinar as well, because we're doing so many for you, but we want to actively do it together. So an example here is this polyp, a large polyp, and we're looking at the surface pattern, and the surface pattern, despite it's a large polyp, it's regular. The second one is we're looking at the pits. The pits are round here, as you can see, and despite this is a large polyp here, we can predict it's a hyperplastic lesion, and this is valid and this is true. Another example is this polyp here. Again, we're looking at the surface. The surface is now irregular, because regular means we have pits like at the normal colonic epithelium. So you can always compare it to the surrounding. It looks different, so it's irregular. And then we can predict the pit pattern morphology here as well. I would say it's definitely a tubular one. And again, this is valid. And then finally, of course, again, we are comparing this lesion, and this looks, again, irregular. We have some villus components here, and then we can predict a tubular villus adenoma. And then finally, again, you're predicting here the surface pattern morphology, which is ulcerated. We're always looking at the most worst part of a polyp, and then we're looking at the pit pattern, and we cannot see any pits here on the surface of the lesion. And then the valid classification predicts indeed that this is a cancer. So now it is your time to participate in this. So we have over 302 participants now, including us as a faculty. So 1, 2, 3, 4, 5 faculty members and 303 participants online. And I want to show you now the next poll. So you can now vote by yourself if this is a hyperplastic lesion, if it's a tubular adenoma, if it's a tubular villus adenoma, or a cancer. And this is a lesion. So at the next poll, you will have the idea to click A, B, C, or D on your screen. And then you can first look at the surface pattern, if it's regular or irregular, at the pit, and then you can come to a conclusion. So we'll show you the poll now. So unfortunately, I cannot see the poll, but we have tested it yesterday. Now I can see it. Oh, wow. Okay, so you can now vote by yourself. Unfortunately, I cannot vote by myself. I got a message here, I cannot vote. But you can vote by yourself, and then we can identify. Most of you are saying it's a tubular adenoma, and some of you are saying it's a tubular villus type of adenoma. Very few are saying it's a cancer, because maybe you have looked at the central part of this image. So this idea of this polyp, if you can gain me control back of the slides, this is a tubular adenoma. So let's go to a second vote. So again, please have a look at this polyp. Again, please have a look at the surface pattern, at the pit pattern, and then please come to your conclusion when we start the poll now. again, it's very important for us always to identify the pits looking very similar to the surrounding mucosa, or is it irregular? If it's regular, then there might be an hyperplastic lesion. Otherwise, maybe something more worse. So hopefully you'll enjoy it. It's the first time ever we are doing really something like this. So most of you are voting it's an hyperplastic lesion, and then we'll have a look at the final result. Again, important, the surface pattern, the pit pattern, and then the conclusion. And in this case, it was a tubular adenoma, although I agree there have been some parts of a mixed polyp. In this case, there was a hyperplastic lesion as well. So this is a large lesion, again, hyperplasia, tubular adenoma, tubular villus adenoma, or cancer. And we have tried to choose real life polyps as well. So again, you can vote. And of course, it's important always to look at the most worst part of the lesion. I would suggest this is something here like this. Is there a surface pattern available? Can we see the pit pattern here? And then let's go to a conclusion in this poll number 3, hyperplasia, tubular adenoma, tubular villus, or cancer. And I'm very curious what you're choosing. Most of you have chosen the cancer. And of course, we can go to the conclusion now. And thanks so much, Claire, for this support in the back, because Claire is helping us here very much from the ESGE. And now we can have a look at the final result. But I can already say it has been a cancer, of course. It's a no surface pattern, it's an ulcerated surface pattern morphology, and no pits are visible. So number 4, let's have a look at this. And I think there might be a learning curve now as well. So what about the surface when we're starting the poll now? What about the pit pattern? And is the pit looking the same like the surrounding mucosa? If it's not, then we say it's irregular. And then if it's irregular, it must be either an adenoma. And then the type is, what about the idea here? If it's tubular branches, or is it maybe a tubular villus one? Or maybe you feel it's looking different. Most of you have chosen it's a tubular villus adenoma. And of course, you are correct with the idea of an adenoma. And if we come to the final conclusion, we can see that in this case, indeed, it has been a tubular villus adenoma. So you can see, indeed, there is also a learning curve, and it seems to be a very short one, because honestly, we have never done this poll before. Yeah, and unfortunately, we can't see each other in person, but you're doing great. So this is, we have 2 more. Yeah, so this is number 5. We can already start the poll, please. So please have a look at the surface, at the pit, and then come to a conclusion. Is it regular or not? We have missed the poll, I guess. Here it is again, and we'll show you the polyp again. Thanks so much, Claire. Hyperplasia, tubular adenoma, tubular villus, or cancer. Is it looking the same for the surface pattern? And you're saying it's a tubular adenoma. My gosh, I'm so proud. So please have a look at the next slide, and then we'll show you the conclusion of this poll. And then you can see, indeed, this is an adenoma, and you're right, it is a tubular adenoma. So if you're interested, 1 more to go, just to keep in time. So again, we start the poll and we show you the polyp. What about the surface pattern? If it's regular, is it irregular? Then you look at the pit pattern. Yeah, is it well structured? Are the pits round or tubular villus, or do you see any ulceration? Sometimes you see in a polyp something like this, which is called a Valley sign. Dr. Rex has described this a couple of years ago in GIE. So we start the poll now, please. And we start the poll, we show you the answers. And the polyp also. Yeah, we have to apologize that sometimes it's moving a little bit, but I feel it is important that everyone is included, and not only us as the speakers. So thanks so much again to SonoScape and the ESGE. So most of you have chosen hyperplastic lesion. I'm really impressed. There seems to be a very strong learning curve for all of you. So we'll have a look at the result. And then when we are going to the result, then we can indeed see that this is an hyperplastic lesion. And you are right. And we have one last one to go for you until we come for the final conclusion. And again, we please start the vote clear. So you can see we are looking at the surface pattern morphology. Is it regular or is it irregular? Again, regular means it looks the same like the surrounding colonic mucosa. What about the pit pattern? If it's round or if it's not round? When it's not round, is it tubular? Is it tubular villus? Or is it only villus maybe? And maybe you also see an ulceration there, and then we can come up to a final conclusion. So we can start the voting. And thanks so much to all of you participating. It's really great. So we can't see each other in person, but we can act at least with each other. And most of you have seen that this is your tubular villus adenoma. Most of you definitely is saying that this is an adenoma. And then if we go to the final conclusion of this last polyp here, and then you can see that in this case, indeed has been a tubular adenoma, although I agree, because there was a little bit of fluid on the polyp, that it appears a little bit like floating, and therefore it was an impression of a tubular villus one. Of course, in real life, it would look totally different. But I think we have seen indeed endoscopy is effective, but we are missing lesions throughout the whole luminal gastrointestinal tract. At least in the colon, we are missing at least 30% of lesions, what we have learned over the past years. I strongly advocate to read the last guidelines from the ESGE regarding colorectal cancer screening from Professor Hassan. Image-enhanced endoscopy using SFI clearly enhances the lesion demarcation and also the detection of lesions. We have seen the idea of the new VIS technology, which allows for an in vivo characterization of lesions. And also we have introduced now for the first time to you the valid classification, which will allow for an exact diagnosis of adenomatous tissue. I think also what we need to show, Cesare, in the future is the learning curve of this study, because this is something what we have experienced today as well with you. And therefore, I thank you very much for your active participation in this webinar. Thank you very much.
Helmut, great presentation, and we congratulate because you are the first to include the velocity in the valid classification. My question to an expert of endoscopy and pathology like you: are we ready to replace histology with endoscopy prediction in our clinical practice, maybe in your office, or do you still see a lot of barriers in implementing endoscopy prediction to replace histology? Can artificial intelligence help in this?
Thank you. I think it's a very important question, most important one indeed. I strongly believe that by using image-enhanced endoscopy, like the VIS technology and the new valid classification, definitely we can do in vivo characterization of colorectal lesions. The barrier will be the learning curve. So it's not that one can start immediately. We have seen it in the results as well. But in order to increase the learning curve, and this is very exciting, I think definitely that in the future, we maybe can use artificial intelligence to increase the learning curve and to help us even more to predict histology in real time. Definitely, I strongly believe this shapes the future of endoscopy, and the valid classification is a very important step for this. Thank you very much. So at least we want to see something new. So we have seen many things today already. Professor Hassan has shown us fantastic videos and fantastic new ideas of the new guidelines. I've shown you the valid classification. Now we are learning from Professor Negrano from Bucharest about dragons, I think. No, it's not dragons, but you're talking not a Game of Thrones, but the game of Crohn. So we want to learn from you about the latest data on endoscopy in patients suffering from inflammatory bowel disease. Thanks so much for being with us.
Thank you very much, Helmut. Thank you everyone for this wonderful webinar. And first of all, thank you SonoScape for inviting me, and thank you ESGE. I will discuss about SFI in IBD. So digital Chroma in IBD, and maybe some artificial intelligence, and how can we predict histology and maybe improve our attitude towards the patients. So what's with this new concept of target? We got this from cardiology with their targets on cholesterol and hypertension. And then our colleagues in rheumatology proved, at least in pediatric population, if we start early, if we follow up on a proactive manner our patients, we can really predict and stop the damage in the joints. So this was the concept. We imported this in IBD, and the target for the moment is the deep remission. And the deep remission, as it's defined now in 2020, includes complete mucosal healing. And everybody knows sometimes how far we are from this concept. And endoscopy still has a paramount role because it can show this mucosal healing. And I show you here some old study before the anti-TNFs that proved that mucosal healing really is important because bears the prognosis for these patients regarding hospitalization and also surgeries and quality of life. So we want to act in this window of opportunity and maybe in the future to act here before the lesions become evident. And this CALM study really boiled the waters 2 years ago because it changed a little bit the way we look at our patients. And we moved from, let's say, more expectant position and based on clinical symptoms and the patient coming to us to a more proactive position to act based on endoscopy and on biomarkers to alter the treatment. And this is not only good for the patients in terms of prognosis and changing their natural history of disease, but also apparent to be cost effective. We know that there is a dissociation between biomarkers and clinical symptoms. And we also know that there is a dissociation, as you can see here, only 31% of the patients has real mucosal healing. So there is a distance between endoscopy and what the patient feels. So endoscopy really remains very important in the treatment and guiding the therapy. It bears a prognostic role and really can change the therapy. We can optimize, escalate or de-escalate. And of course, we know from the STORY trial, it's very important in stopping therapy because we know that if we have mucosal healing, we can attempt to stop therapy with some good results. We know that white light has the weak points of not really seeing some subtle changes, some inflammation, and a lot of ink was drawn to this in the debate to classical Chroma. And then we have digital chromoendoscopy for the last, let's say, 15 years. And we have even a score from the Yakuchi, from Marietta Yakuchi's side. It's called the Picasso. And apparently it seems it has a good reliability between raters and also it correlates well with histology. All the manufacturers, you have here two studies by Kudo and by Silvio Danese in Milan with NBI that really reveals subtle lesions and inflammation. Professor Neumann beautifully showed in this study that eye scan can show some modifications that can predict there is inflammation there, although the patient is asymptomatic. And you have this Japanese study with the data with LCI, so Fujinon, that also proves this kind of light, special light, can improve the diagnosis of subtle inflammation in patients apparently asymptomatic. So in real life, how can we use digital chromoendoscopy? It's very important to really change our therapy and to predict recurrence. And after all, this is very useful in terms of pharmacoeconomics and really prescribing the good drugs and really knowing how to stop the drugs when needed. In this way, avoiding risk of infection, for example, or cancer. The discussion is very complicated, and every one of you knows that the scores were designed for activity and not really for severity and mucosal healing. The data is conflicting, and I selected only a few studies to show you that assess CD between 0 and 2 might be a target, or also in the extent trial, a score below 5, or in the Sonic trial, just a reduction with 50%. So how strict should we be? I think the answer will be in the future. I show you these images of white light and SVI in a Crohn's patient. You see deep lesions, severe ulcerations. And when using SVI, you can see that the quality of the image and the demarcation and the inflammation is really easier to see and better visible. What about post-operative monitoring? We have a lot of patients that had surgery, and we know that most of them will relapse and will relapse soon. We propose them to come to colonoscopy in 6 months in order to start the treatment if needed, because we know that if we do not treat the right patients, almost 80% will recur in their disease. Not every ulceration should be treated, of course, and you have this definition proposed by the pontiffs of IBD, the IO-IBD group. Only the lesions I2B should be treated, so more than 5 of those lesions. So you have this image in a young male that I have as a patient, and using SVI, you see that there is more clear demarcation. You can guess a degree of stenosis here, and maybe you would feel like treating this patient and not letting things like that. You have here another patient with a funny montage, but surgery is at the beginning. But when using the SVI, you can see here that the lesions are more clearly demarcated, and at least in this area, inflammation is more visible. Are things simpler in UC? Maybe they are, maybe it's simpler to predict. And I read with pleasure a recent study this month about the colon capsule endoscopy in UC, and the patients that had the low score on colon capsule, so mucosal healing, had a better prognosis. Is the same in endoscopy. You see here some white light in a patient that is completely asymptomatic during his treatment. If we look carefully with SVI here and here, you see some degree of inflammation and maybe an exulceration here with VIST. So I wouldn't feel comfortable to stop. Maybe I will ask the patient to come soon. SVI here in this images clarifies the scarring. So here I think patient is on the good course. And here you can see that SVI shows some degree of mucosal bleeding and submucosal bleeding. So in this patient, clearly there is some activity. We evaluated only 12 patients that are in remission, and we showed that using SVI and targeting our biopsies show a degree of histology of active inflammation and infiltrate in the submucosa of 90% as compared to only 50% using white light. So I think it's in the eye of the endoscopist, so it's very important to bear this in mind, but also to use the right light. Is it doable in the real life? You see here a study that shows that only 10% of colonoscopies really are using a scoring system in the real life. This is a French study, a little bit old. And here are some data from Berlin that shows endoscopic healing in the treat-to-target monitoring is not as used as we would like. Not even the patients accept endoscopies in a proactive manner. I think this is a problem of the future, and maybe the way we explain and resources and access. So Future issues in digital chromo, we have to increase their use. We have to discuss about semiology and maybe a scoring system that will be applicable universally, no matter of the manufacturer of the scope. We have to validate in more extensive trials to see if these lesions can really alter the prognosis of the patient, the relapses or the frequency of the hospitalization and recurs to surgery. And maybe Professor Neumann, as the chairman of the IBD group at the World Endoscopy Organization, and ESGE will increase the collaboration with ECHO, and maybe we can work this out in the near future. So, dear colleagues, dear chairman, I think digital chromo is very important. Of course, it's in the eye of the endoscopist, but with the right tool, with a good endoscope, with the good light, we can even predict histology and see which patients need to be followed up more closely in this treat to target way we use now is the best dogma we have for the moment. And of course, I invite you all to participate in studies and really to increase the bond between ESGE and the ECHO organization. So thank you. I hope I stick to the time because it's very crowded night and very interesting. Thank you very much.
Thank you, Lucian. Absolutely awesome learning from you about the game of Crohn's. And I think indeed patients with inflammatory bowel disease, they are so challenging, is it? It's absolutely awesome listen to you and to the new ideas. And you have intensively talked about image-enhanced endoscopy and prediction of mucosal healing and deep clinical remission. What about detection in the future? So at the moment, the guidelines still refer to optical chroma endoscopy, so the dye-based chroma endoscopy, so to traditional dye spraying for detection of lesions in IBD. Do you think in the future we can rely on SFI maybe in this specific circumstance as well?
I'm sure we will, because if we ask, we all talk about it and very few are really doing it in real time, except for the patients with all diseases when we have to do chromo. But this is more elegant, it's easy to do, it's you push a button, and I'm sure we will have soon enough algorithms that will help, and maybe we can validate this in future work. So I think it's there.
Thank you so much, Lucian. Fantastic talk again, and also I hope to see you very soon again. And to visit Bucharest also. And I've visited already Malaga a couple of times, and Pedro, you have been a fantastic host all the time. You have such a fantastic hospital. You're doing so many cases. You told me you have done a couple of ESDs today as well. And of course, there could be no better expert than you today talking about third space endoscopy and talking about the trends in endoscopic submucosal dissection techniques. So we are so keen to learn now from you about the latest innovations in this field. And I also know that you're using the SonoScape scopes now for a very long time and doing very, very difficult procedures with those scopes. And of course, we're very keen to learn from you about the trends now of endoscopic submucosal resection techniques. Thank you very much.
Thank you. Thank you, Helmut. First, I want to thank to SonoScape and ESG for the opportunity to participate in this meeting. It's really an honor for me to be with such a great college. And I want to speak about, I want to speak about ESD and as I see the future of the ESD. As you can see here in this slide, the number of articles in ESD and the interest in ESD has become higher and higher with the years. And as you know, the standard ESD is now the gold standard in the managing of big or advanced lesion. You please note here in this esophageal cancer how we use the SVI mode of the SonoScape system. I really like this mode for detection, for see the edge of this esophageal cancer to make easier to mark. And as I say, the standard ESD is now the gold standard to remove this kind of lesion. And it's true that it is technically demanding, and it's true that it takes you time. But once you are used to do this kind of technique, you are going to be able to treat in a safer and better way your patient. But in this presentation, I don't want to speak about regular ESG. I want to speak about the future of these techniques. So, because normally the people feel move in the area where we feel comfortable is the comfort zone, and in gastrointestinal endoscopy, the comfort zone is the intraintestinal space, and it's limited by the muscularis propria. So everything inside the muscularis propria is a safer place. You feel okay working here, but outside the muscularis propria is terra incognita. It's the deepest space. You know, we have the first space in endoscopy is the intraintestinal space. The second space is the extraintestinal space, the peritoneum. And the third space is the submucosal space. And we have a lot of experience now in third space endoscopy. And as you know, with regular EMR or ESG, you can remove lesion located in the mucosa or even in the submucosal layer. But for lesion located in the muscularis propria or in the serosa, you have to do different techniques, different from ESG, to remove this kind of lesion. So you have some time to break the barrier, and this is what we are going to speak about. For third space endoscopy, we have a lot of techniques, and all of them are very similar. The more used technique of third space is POEM for achalasia, but we have G POEM for gastroparesia, C POEM for Thenker. We have techniques to treat subepithelial tumor we are going to see, or even stenosis. And the more usual technique that we have in third space is POEM. I'm going to speak very few about POEM because all of you know it. Only in this slide I want to show you is a slide from my good friend Eduardo Albeni. Like any kind of achalasia type 1, type 2, or type 3, or even jackhammer esophagus can be treated with POEM better even than Heller myotomy. What I want to show you is a video of gastric POEM. All the tunnel technique, POEM, G POEM, C POEM are very similar. You have to do a mucosal entry. You have to create a tunnel until you reach the target that you are going to treat the target, and then close the mucosal entry. So in this case of gastric POEM, we are creating the mucosal entry. After we create the mucosal entry, we can dissect, creating the submucosal tunnel until we reach the pyloric arch. And once we reach the pyloric arch, you can see here the pyloric arch. In the G POEM, what we do is cut completely the muscle fibers of the pyloric arch to remove the tension. And you can see in this video how we can go step by step, very precise, very controlled, removing any kind of muscle fiber and cutting completely the pyloric arch. Normally in G POEM, we cut the pylorus and 1 or 2 centimeters of body muscularis propria. I want to show you the final result of the myotomy. We are finishing. You can see here the pyloric arch completely closed. And then, because I have made a perforation here and I have the mucosal entry here, I only need to close the mucosal entry. And with 4, 5, 6 regular clips, normally you have done the work. The POEM are very similar in concept. The next technique I want to speak about is full thickness, because I'm totally in love with the treatment of subepithelial tumor. Are two kind of different techniques, the exposed and the non-exposed technique. In the exposed technique, you are going to create, or maybe you need to create a perforation of the muscle layer. And we have a tunnel technique, like STER, are very similar to the POEM, and non-tunnel technique, submucosal excavation. And the And in non-exposed technique, you are going to have no perforation because you are going to close the perforation before you do it. And in this moment, the only device that we can use regularly is the Obesco full thickness resection device. I'm going to pass through the full thickness because it's all of you know, but I want to stay in the exposed full thickness resection. In the exposed full thickness resection, as I said before, maybe you have a perforation, so you have to keep in mind that you will need to close the perforation of the patient for not to have a complication. And the improvement in the skills in this field has allowed that we develop better techniques to close the perforation and that we have lost our fear to make a perforation. For a small perforation, normally with regular clips, the work is done. For perforation bigger than 1, maybe 2 centimeters, probably it's better to use Obesco over the scope clip. For perforation bigger, maybe a good technique to use is a loop and the clip technique. In non-exposed technique, in non-tunnel technique, endoscopy submucosal excavation, the technique is very similar to the regular ESG. You are going to start dissection the submucosal plane, and then you are going to continue the mucosal through the muscularis propria until you completely release the lesion from the muscular bed. Maybe you need to do the perforation. It's better if you try to avoid. And I want to show you these cases. All the therapeutic procedure I do with the SonoScape therapeutic upper gastroscope because he has a big working channel and has amazing retroflex maneuverability. So in this case, it's a GIS located in the G junction. It's a 2 centimeter GIS and it's in the submucosal plane. In this case, I have removed before the mucosal layer. You see the retroflex view of the lesion. And now we are performing a deeper dissection. You can see how the tumor is in the surface of the muscularis propria. So you start to cut the muscularis propria and cross your finger for not to have a perforation. If you have a perforation, you have to close, but always is better try to avoid. And you can see how it's very easy to differentiate the subepithelial tumor from the regular muscular layer. Step by step, we exit the tumor from the muscular layer. And at the end, you are going to see the tumor hanging from a little part of little fibers of submucosa. This technique, maybe you think it's very time consuming or very difficult to do, but it takes 1 hour and a half, I think, to do completely. And in this case, I have no complete perforation of the esophagus, so no need to close. And this is the specimen, was a GIS, the lesion was removed completely. And my favorite technique about subepithelial tumor resection is STER. STER was described by Su in 2012, 1 year after the same author described the submucosal excavation. And the technique is very similar to the regular poem. You create a mucosal incision at some distance of the lesion you are going to treat. Normally 4 or 5 centimeters, you create the submucosal tunnel until you reach the lesion. And once you reach the lesion, you detach the lesion from the muscularis propria. And in this technique, it doesn't matter the deep the lesion is because it doesn't matter really you have a perforation because you are going to close the entry of the tunnel only. And it's a very safe technique. And as for that, you are not going to need a full thickness closure. Normally with regular clip, you are going to have the work done. The only bad part of the technique is that it's difficult to remove lesion with more than 4 centimeters. This is a schema of the technique, but you are going to see a video of a subepithelial tumor located in the serosa. This was again a GIS tumor. is what located here in the upper part of the gastric body. And in this case, I made the mucosal entry in the G junction, and this was a mistake. In this case, it's easier to do the mucosal entry in the esophagus and go through the cardia to the lesion. But anyway, we do the mucosal entry, and we create the tunnel and the submucosal layer. Please note here in the gastric cardia, you are going to find a lot of big vessels. So in this area, we have to do a very careful dissection for avoid bleeding. The vessels are very big. And this is the idea. Create the mucosal channel, leave the mucosal plane totally intact for close the perforation, and continue the dissection until you reach the lesion. I want to show you, unfortunately, I have to change the endoscopy tower because we need for other case. But I want to show you how difficult it is to see sometimes the tumor because it's very deep. So in this case, you see the tumor is very deep. It's practically impossible to see. Okay. The GIST is located here, practically is outside the stomach. So again, carefully we dissect plane by plane the mucosal plane. And soon we have a perforation, and we know that the lesion is more outside the stomach than inside the stomach. So we have to continue the dissection through the peritoneal cavity. This is the wall of the stomach, and the lesion is hanging out. And at the end, we remove completely the lesion, and it's a round lesion, so the lesion drops in the peritoneum, and I have to go with the scope to find the lesion that was located between the liver and the gastric wall. Is here, checking outside the lesion, and then it's so easy that the close perforation, the mucosal entry, like any point. Maybe you think it's a very aggressive technique, but the patient was discharged home next day, the next day. This is the specimen. And when we use the submucosal excavation or stir, for be clear, if you can use, I think that if you can use a stir, it's always better to do a stir. And you can use a stir in all the esophagus and in all the areas of the gastric stomach. But in the upper gastric cardia and the lesser and the distal lesser cubature, you have to use submucosal excavation. If you can use a stir, is always better. Only one article for you is a meta-analysis of the efficacy of the stir. We have 1,041 patients, complete resection 97, block resection 94, and complication 4. And the last technique I have for you, I'm finishing the presentation. I think it will be the future of the specialty too, is a treatment for the GERD, because it's a very prevalent disease and we don't have a good solution for GERD, no endoscopy or even surgical solution. And this is a technique described by Inoue. It's arms and reflux mucosectomy. And this is my change of the technique because I use a multiband device to resect the submucosal, the gastric submucosa. And the idea is to resect in front view or in retroflex view the most of the gastric subcardial area to create an stenosis that helps the patient to have less reflux. I want to show you the final aspect only, and this is how we feel the arms technique. It takes 25 minutes to do. I'm finishing the presentation. What future advances do we need? We need better, safer closing device. We need more data on efficacy, infection, bleeding for any kind of tumor. And we need to know with more studies what will be the place for endoscopic resection for this kind of tumor. in front of the surgical resection. And finishing the exploration, finishing the presentation, I think third space technique has emerged as a less invasive alternative to surgical treatment for gastroparesia, diverticulum, achalasia, or subepithelial tumor. And we are going to see a bit development of techniques in these areas. And maybe you think that doing this kind of techniques is as difficult as do this Rubik cube, but with a lot of patience, at the end of the day, you will come to do the technique fantastic. So for me, finish, and thank you very much for your attention.
Wow, awesome. Thank you so much, Pedro. What a fantastic discussion and talk. Unbelievable. So for me, it's always so impressive, and I've seen you so many times live, and we've done cases together as well. You're really doing the most difficult procedures. And I'm always wondering, do you ever need your surgeon? Do you have a surgeon in your hospital, or are you doing everything just from the luminal side?
Yes, I have a surgeon with me, but I never call him.
I guess, yeah, you're not the best friends.
I don't want to see the surgeon in my endoscopy room. It's better not to see.
Yeah,
no, I have no need to operate. Only one cases of a colonic ESD, and have a perforation in another place different for the what the lesion was. But for this kind of lesion I have showed today, I never use surgical.
Ah, that's fantastic.
Thanks
And what we have also seen from you, so doing those most difficult cases, but I've also seen you're mostly using the SonoScape scopes for those procedures. So regarding the maneuverability, before we have already seen the non-inferiority trial regarding, you know, the key performance parameters in endoscopy, that SonoScape is not inferior to other brands like Olympus and Pentax Medical. So what do you feel from the therapeutic side? Is it inferior to use a scope, or I guess not, because you're mostly using it for those most difficult procedures like submucosal tunnel endoscopic resection and so on?
Not today. I only use SonoScape for therapeutic, upper therapeutic. And I have Olympus in my hospital. I have the two systems in the same room. I have 118 Olympus, and I can use what I want. I always use SonoScape because for me it has better maneuverability. Okay. And therapeutic gastroscope is very thin, so it's very easy to move in the channel.
Okay, Pedro, thank you so much again. Fantastic talk and very exciting. Unfortunately, we are not able to see the talk of Professor Giovannini, but at least I want to show you that indeed we are pushing. We do not only want to push the boundaries, but we are pushing the boundaries of endoscopic excellence, and even SonoScape is doing this. But also there is a new thing what is coming. So SonoScape is now also introducing new scopes, and those are a linear scope, echo endoscopes as well, and this is also something what we definitely want to show you. So very soon there will be a radial echo endoscope and a linear arrow echo endoscope as well from SonoScape company. So much more to come in the upcoming months. So at the end, I would say it is now my topic to close this webinar series. Again, I want to thank all the participants. First of all, I want to thank all the people outside for joining us here for this ESGE satellite webinar series. Definitely, I want to thank very special today, even the ESGE and the people in the back, which is David Inc., but also especially Claire Guy. We have done a very spontaneous job today, and definitely I want to highlight those people in the back. Without this massive support today from the ESGE, this webinar would have not been possible. So thank you so much, Dave and Claire, for your fantastic support, and all the best to the colleagues in Munich. And we are very happy that we have the ESG as our society supporting our passion and pushing the boundaries of endoscopic excellence. I want to thank SonoScape company for bringing us all together, learning together, and for making this possible. And also, of course, I want to thank all my colleagues here, and come back live, please. Show your faces to the people. Pedro, Lucian, Cesare, and maybe even Claire and Dave, you're also there. You can show your face as well, because you have done such a great job. We are not alone. It's challenging times, but we are not alone. Thank you so much. Stay safe and see you soon. Bye-bye.